Good afternoon, everyone. Welcome to Internal Medicine Grand Rounds. I've been informed this is the last Grand Rounds of the year, the season, so to speak, or maybe the year, we should say. So we're saving the best for last. Dr. Megan Morales. Now, it's a huge pleasure and honor for me to introduce Dr. Morales. Dr. Morales came to us actually in February of this year, like at the end of February, right before COVID broke, and was immediately granted emergency privileges to start seeing patients. So we thank her for that, particularly covering the COVID service. A little background on Dr. Morales. She went to college at the University of Maryland, got a degree in health policy and medical ethics, and also minored in Latin American studies. Later, she went to attend medical college or medical school at George Washington University School of Medicine, where on graduation, she received the Gold Humanism Honor Society Award. As a resident, she moved across town to Georgetown, where she did her internal medicine training. It was chief resident year and stayed there for fellowship, where she did her infectious diseases fellowship. Now, with respect to her fellowship, I'd like to mention a couple of things. First, that she was recognized with the Hope Award, really in recognition of excellence and compassion in providing care to patients in infectious diseases, and was also inducted at the time to the AOA Medical Honor Society. After her general infectious diseases training, Megan then went on to do transplant and oncology infectious disease subspecialty training or subspecialty training at Johns Hopkins University Hospital. Then from there, she returned to the University of Maryland to be an attending physician both with solid organ and transplant and oncology ID services, and was an ID fellowship assistant program director until we were so fortunate to recruit her to VCU to be our transplant infectious diseases director, a program which is growing by leaps and bounds. Now, she's published multiple articles on transplant and related infectious diseases. She's a fellow of the American Society of Transplantation ID Community of Practice. And for fun, I have to mention a couple of things here. She is a foodie. She's been in Richmond, but since everything's been pretty much shut down and it's not safe to go to restaurants, she's not had a chance to really experience the Richmond food scene or restaurant scene. We hope you'll be able to do that soon, although she's quite well connected or well aware now of the local pizzerias that have delivery, so that's cool. But most importantly, her and her 2-year-old daughter have a YouTube cooking show, or YouTube cooking channel, so go check it out for age and I guess time appropriate recipes or during COVID-19. I look forward to seeing your cooking show, but more importantly, I'm looking forward to seeing and listening to your Grand Rounds next generation sequencing for diagnosis of infections and neutropenic fever. Take it away, Dr. Morales.
Thank you so much for the introduction. So I'm sure people might have been expecting an ID doctor to present about COVID for Grand Rounds, but I'm going to give us a COVID-free hour here and talk about some exciting new diagnostics that we've been using here increasingly over the past few months. So we're going to focus on next generation sequencing for diagnosis of infection, here specifically in neutropenic fever. All right. So for our objectives today, we'll understand more about the traditional and standard diagnostic pathways in neutropenic fever, but also develop an awareness of what the role for next generation sequencing has been to date, and then identify potential benefits and pitfalls of next generation sequencing tests. So we'll start with a case. This is a case of a 63-year-old male with newly diagnosed AML who was admitted to VCU for induction chemotherapy. He had been feeling sluggish, more easily dyspneic while working on his farm harvesting grains, and then was diagnosed with AML. He has a past medical history of gout and hyperlipidemia. Social and family history was non-contributory here. He had no history of international travel, has always lived in Virginia. They are on well water, but drink only bottled water at home. One of their farm workers had been diagnosed with tuberculosis 30 years earlier, but that person's family had never seroconverted when they were tested, and the patient told me that he was never close enough to that worker who had been at any risk. He had been a cattle farmer until earlier this year, and then has been growing crops only since that time, and they have no pets in the house. His admission labs were notable for leukopenia with a white cell count of 1.2 and an absolute neutrophil count low as well at 100. He had some anemia with a hemoglobin of 7.9, platelets of 170, and a baseline creatinine of 1.3. He was started on prophylaxis with levofloxacin, fluconazole, and acyclovir, had a Hickman place to begin induction therapy, and then developed a neutropenic fever to 39.3 degrees. He was changed empirically to vancomycin following a few days of fever, All of his blood and urine cultures remained negative. Chest X-ray was clear without any infiltrate. He did have a cracked right second molar, but per his OMFS evaluation, there was no concern for infection there. I didn't see any histo or cryptoserologies or fungal biomarkers sent at that point. So at this point, the patient has had several days of persistent neutropenic fever despite antibiotic use. And so this patient would be considered a high-risk patient, which we define generally as prolonged duration of neutropenia greater than 7 days, and also profound neutropenia with an absolute neutrophil count of 100 cells or less. Sometimes that can also relate to significant comorbid medical conditions as well. But for this patient, clearly meets by both prolonged duration of neutropenia and profound neutropenia. And so for him, he had, of course, been having daily examination history, repeated negative blood cultures, and no, other focal signs of infection at that point. The patient had been receiving fluconazole or anti-yeast prophylaxis. And so traditionally, your next step from there would be either preemptive monitoring with CT and serial fungal biomarkers, or expansion of empirical antifungal therapy to a mold active agent. So I'm going to pause here since I mentioned that our patient had been started on fluconazole prophylaxis, just to comment on antifungal prophylaxis and induction chemotherapy for our patients with AML. So this multi-center randomized controlled trial looked at the use of posaconazole prophylaxis as compared to fluconazole or itraconazole in AML patients who had prolonged neutropenia. Prior to this, fluconazole prophylaxis had been standard of care after they showed a significant reduction of invasive fungal infection and any cause mortality in patients undergoing stem cell transplant. And this is extrapolated to patients undergoing induction chemotherapy for AML as well. So patients in this trial received prophylaxis until they either recovered counts and were in complete remission, until invasive fungal infection occurred, or 12 weeks, whichever happened first. They had approximately 300 patients in each arm, and most received fluconazole in the standard arm. So again, kind of comparing your mold active versus yeast coverage along with fluconazole. And they did find with the change of posaconazole, fewer proven or probable invasive fungal infections and fewer cases of aspergillosis, as well as significantly longer survival. Serious adverse events were potentially higher, the most common being GI side effects. They also performed weekly throat and stool surveillance cultures and saw a reduction in incidence of fungal colonization, similar among all three, but more importantly, no trend toward azole-resistant colonizing strains in their monitoring cultures. The number needed to treat to prevent one IFI or invasive fungal infection was 16, and the number needed to treat to prevent one death was 14, so pretty promising there. The second study was outlined here, also investigated the impact of antifungal prophylaxis in AML patients undergoing induction chemo, but in a setting with a low incidence of invasive fungal infection, which they defined as between 6 to 8%. With the supposition that some centers had not adopted the use of antifungal prophylaxis because they were uncertain of benefit in a low incidence setting. So they retrospectively reviewed just over 100 patients, with 56 receiving antifungal prophylaxis, primarily with posaconazole. A handful of 7 or so did still receive fluconazole, which may have been a little bit of a confounder here. But they concluded that antifungal prophylaxis was associated with lower in-hospital and 30-day mortality, numerically less fungal infections, and less use of empiric antifungal therapy. So taking a look at the guidelines here from the National Comprehensive Cancer Network, you can see for AML patients and neutropenia that they do recommend posaconazole or mold active prophylaxis. So accordingly, this has been a recent change adopted by the Antimicrobial Stewardship Committee to change our in-house protocols. And so you can see now that for patients with AML, we will actually be using posaconazole prophylaxis. And so we're updating that internal guideline this year for that transition as well. So although our patient here had been admitted earlier in the year with fluconazole, I did want to address that, why we are making this change in-house and how that will impact our patients with neutropenic fever. So to get back to our patient, so we went ahead with CT scans with this patient, and they did find some typhlitis or neutropenic enterocolitis. He had also developed some diarrhea by that point and was tested positive for C. diff. We stopped his vancomycin due to lack of positive cultures for MRSA or any resistant gram-positives. His fungal biomarkers from the blood were negative, so beta-D-glucan or fungitel less than 31, and a galactomannan or protelia was also low. He defervesced and then completed an empiric course of cefepime and metronidazole. Unfortunately, the patient had residual disease and so had to undergo a second round of induction chemotherapy. He had a single fever 2 days later and then sustained fever starting a few days after that. At that point, his diarrhea had resolved. He continued on the C. diff treatment and then prophylaxis. CT scan showed that his neutropenic enterocolitis was improving as well. Symptomatically, that had resolved. He continued to have negative blood and urine cultures. VRE screening was done, which was negative for any VRE colonization. He had empiric escalation of therapy, which was not based on any culture data, but had been escalated at that point to meropenem as well as anti-mold coverage. However, his fevers persisted around the clock, and he was actually having really severe rigors along with these high fevers. So essentially it was on Tylenol around the clock just for management of symptoms at that point. So just to recap, by this time, he had had persistent neutropenic fever despite resolution of the prior processes, meaning the neutropenic enterocolitis and C. diff, negative cultures, unrevealing CT imaging, negative fungal biomarkers, and despite empiric escalation of antimicrobial coverage. So when a patient is stable, we would typically hold with current coverage, even if they're still having fever, and continue to monitor for any developing infections while they remain neutropenic. However, given the severity of his fevers and symptoms, we did decide to pursue additional testing via sequencing. So in comes the Carius Test. So the Carius Test is an offshoot of work from Stanford University, and the company is now based in Redwood City, California. They perform cell-free DNA testing from the serum samples. So cell-free DNA has been used successfully in other settings, including prenatal screening and organ transplant rejection screening, but the clinical use in the diagnosis of infections was less well established. Places where they have studied it and used it successfully have been with endovascular infections and endocarditis, pneumonia, neutropenic fever, fungal pneumonia, or other infections in immunocompromised hosts, and importantly have a fast turnaround. Usually from the entire process from DNA extraction through analysis is typically completed within 28 hours. So this is a diagram from Carius, showing their process here. And so here you have your sample patient who has, potentially widespread infection. Here they're highlighting pneumonia, that they're actually able to pick up bits of cell-free DNA from the serum sample, which they then analyze and send you the finalized completed report. So it's actually just a single tube in a standard PPT tube, 5 mL, which then is sent off overnight to the company for DNA extraction. They do the sequencing and then compare to their reference genomes. So they use reference genomes from the National Center for Biotechnology Information, which is part of the National Library of Medicine, for both human genome and microbial genome, and then ultimately generate the final report for you with any quantitative amounts of relevant pathogens they identify. So they actually have a very broad range here of over 1,000 pathogens. So you can see here what they're able to test for as far as fungi, bacteria, viruses, and other pathogens. So if you are ever concerned about a particular pathogen that you're searching for, they do have a complete list on the website for you to see if it is included in their database. It's important to know that organisms classically associated with environmental contamination were excluded from the clinical reportable range database in order to prevent some false positive calls. So for instance, Propionibacterium acnes, certain Acinetobacter, which are environmental contaminants generally, as well as Methylobacterium species. So that's important to know, depending on what you suspect or what you're concerned about. Is it actually in their database, or would it be excluded as a probable contaminant? So here's an example of what the final report is. So they list the pathogens present that are present again in that statistically significant amounts, and they quantify it as well as an expression of molecules per microliter. They give you a reference range to help with interpretation, and then they also offer clinical consultation with one of their staff ID physicians for those who might want additional help interpreting some of these results. So let's take a look at a report in closer detail. So what you'll get is basically this plot showing the concentration of each microorganism identified in the sample. So they compare it to the concentrations of the same microorganism reported in the last 1,000 specimens reported by Carius. And then the star, which you see here, shows the patient's MPM, or the molecules per microliter. The black dots show the MPM results in the other specimens where the same microorganism is reported. And then at the bottom, you can see how many of the last 1,000 specimens tested had this organism. So here, 14 of the last 1,000 had DNA from Pneumocystis present. The last box shows you that 0% of the reference asymptomatic people tested had Pneumocystis present in their samples, meaning that generally you would consider it pathogenic. Of course, I'm sure this is not a surprise to anyone here, but the presence of microorganisms is not always synonymous with actual infection. And so there are limitations to this, and it's important to you as either the ID consultant or to the ordering medicine physician to determine the significance of these results. So Carius reports quantitative units, but there's no really well-defined threshold that distinguishes colonization from infection. The quantity report, or the MPM value, can be impacted by one of several things: the location of the infection and its angioinvasiveness, prior or ongoing antimicrobial treatment, or the genome size of the organism. There can also be some noise, so to say, from endogenous flora, especially in patients with impaired GI mucosa, such as those with AML undergoing induction with cytotoxic chemotherapy. While the MPM values of different organisms may not be comparable to each other, you can actually trend the MPM over time with the same organism to respond to see how it responds to treatment. The Carius Test pathogen-specific reference ranges have also been established using cell-free DNA from healthy donors. So in one study from University of Miami that we'll discuss shortly, one patient had identification of tortenovirus, which is considered non-pathogenic, though may actually correlate as a marker of net immunosuppression or infection, as well as lactobacillus, which is a part of normal GI flora and often a contaminant. However, an immune-compromised host may actually be a relevant and pathogenic species. So it's important to remember that although this test is often deployed in neutropenic patients or immunocompromised patients, the comparator MPM numbers are coming from a healthy asymptomatic population who probably has a very different genome. And then last but not least, to also mention, the cost of this test is about $2,000 per test. And so that's something to be considered in terms of test stewardship as well. In many ways, though, it still sounds like a wonderful test, right? So does it actually work? So this was one of the earliest studies released. This was a small pilot study with 10 patients from the University of Miami Cancer Center. Half of those they enrolled actually had already had an established diagnosis via conventional methods, since they were hoping to evaluate the positive agreement between next generation sequencing and conventional diagnostic testing in these patients. So among the 7 concordant patients, 5 had positive concordant results and 2 had negative concordant results, meaning both the cultures and Carius testing were negative. So you can see what pathogens they did identify here among their concordant patients: Aspergillus, Pneumocystis, Steno, CMV, and adenovirus. So the adenovirus results from the Carius test actually triggered follow-up adenovirus DNA PCR testing and subsequent antiviral testing. So that had not been picked up through their traditional methodology. The patient with Pneumocystis pneumonia had already been on 3 days of Bactrim by the time of the next-gen sequencing testing, which is helpful to know that it was still positive at that time. The Aspergillus patient had actually received over 120 days of anti-mold therapy by the time of testing. Among the discordant patients, 2 patients who had negative cultures had a positive Carius test, including Rothia and E. coli. Both completed a course of an antibiotic therapy and had resolution of fever and hypotension. One kidney transplant recipient had an Aspergillus fumigatus perinephric abscess, and the Aspergillus cell-free DNA levels were detected in the plasma sample, but were actually below the positive reporting threshold, but had been on quite a lot of antifungal therapy at that time, which clearly would impact test results. So in a moment, I'm going to review some additional studies that have published about the reliability of Carius testing in this group. But just want to pause to mention the invasive fungal infection classification scheme. So these definitions were established for research use, but since we'll be mentioning them in the context of research studies, I thought it might be helpful to review them here. So proven is any patient with a fungus identified by histology or culture of tissue from the site of disease. Probable is where most patients tend to fall in terms of you have the right host factors, the right clinical criteria, meaning a comparable CT chest with cavitation or something that would suggest a fungal infection, and then the mycological criteria. And so that could be culture or fungal biomarkers. So that's where the majority of patients in clinical practice tend to fall. So looking at some other publications regarding cell-free DNA next-gen sequencing for fungal pathogens specifically. So the Fred Hutchinson Cancer Research Center looked retrospectively at 57 stem cell transplant patients who had proven or probable pulmonary invasive mold infections, and 19 controls with non-fungal pulmonary infections. They all had blood collected within 14 days, which was analyzed later by Carius testing. Among the 57 proven and probable cases of invasive mold infection, they identified pathogenic molds in 15, or about 26%. The rate of detection was higher at 32% for patients who had serum samples collected within 7 days of diagnosis instead of 14. The Carius test had actually, interestingly, a higher rate of detection in non-Aspergillus molds, which in this series had included Rhizomucor and Cunninghamella. There is some data from blood Aspergillus PCR indicating that the signal can wane after more than 7 days of treatment. So likely those that were collected significantly after the fact of starting treatment were negative for that reason. The second study by Armstrong enrolled 40 at-risk pediatric hem-onc and stem cell transplant patients. And Carius testing identified fungal pathogens in 7 of the 40 patients there. Results were identical in 4 of the 6 proven cases, which included Aspergillus fumigatus, Candida, and Rhizopus. 2 of the cases, Rhizopus, that was identified on a skin biopsy, and Aspergillus isolated only in week 4 of culture from a lung biopsy, had been missed by Carius testing, though they postulated that there was probably a lack of bloodstream penetration in the case of the skin infection, and they questioned the actual pathogenicity in the case of the late lung culture growth. So not sure that those were misses versus potentially not true invasive fungal infections. The next one that we look at is by Hong et al., who used frozen stored blood to perform Carius testing sequencing on 9 patients who had proven invasive fungal infection via culture or ribosomal sequencing. And this was from a variety of sources: lung, lymph node, heart, brain, sternum, and small bowel. So in 7 of these 9 cases, plasma next-gen sequencing detected the same fungus as the biopsy tissue. In one case, Carius identified Aspergillus lentulus, which is interesting because conventional microbiology had only gone as far as identifying Aspergillus fumigatus species complex. So these are actually morphologically identical and share 91% sequent homology. But Aspergillus lentulus is actually a significantly different susceptibility pattern with a lot of decreased susceptibility to azoles. So in this instance, Carius testing exceeded traditional diagnostics down to species level identification, which would impact your treatment of a patient. And the 2 instances where Carius did not identify the biopsy-proven pathogen, one sample had been collected 20 days after the biopsy and after over 2 weeks of antifungal therapy. The other was identified in raw data, but again had numbered below that reportable threshold for positive reporting. And so again, we're seeing kind of the trend here of where to appropriately use this is early on in treatment. And again, to be cautious about using that positive threshold under certain scenarios, either in immunocompromised hosts or for those on treatment. In 6 of the 9 patients, multiple organisms were identified, including both viruses like CMV and HSV1 and bacteria, including Staph epi, Pseudomonas, and mycobacterial species. These couldn't be confirmed as true infections since none had grown in culture, although they had not actually sent AFB cultures on all of these patients. And again, that can fall sometimes under the concern about noise, where you're getting multiple pathogens and have to determine what is a true infection versus colonizer. So the main takeaway here is that prolonged antifungal therapy of over 1 week may genuinely interfere with detection of fungal DNA. And so there is an exception that they found in some studies for patients with really prolonged, profound neutropenia that may have a positive signal for a longer period of time. So we'll touch briefly on some additional concordant studies. So among patients with, again, very low ANC, which is really where we're targeting again in our sort of neutropenic fever population, there was a 90% concordance between Carius and blood culture results. And then a 31% negative agreement, again, meaning that both tested negative. Among lung transplant recipients with serial plasma sample collection, they actually found good correlation between CMV PCR tests and cell-free DNA from CMV. And then cell-free DNA had also revealed undiagnosed cases of infection. So again, sometimes more sensitive than our traditional methods. And so some of those previously undiagnosed infections included microsporidia, adenovirus again, polyomavirus, and HHV8. In the last study, there were 82 Carius tests, 27 positive by conventional methods, and 60% had the same organism detected by Carius testing. Again, a handful of 7 did have additional microorganisms beyond that one. 11 had a positive micro with negative Carius, which included sort of a span there you can see. Again, likely the most impactful thing there being time on therapy, resulting in a negative result. So I think it's been clear from the last 2 slides that really the time on therapy can be one of your main impactful things in terms of getting a positive result. So what about sending it earlier? So this was a small publication. They just reported on 3 of their patients, but they had been diagnosed by cell-free DNA next-gen sequencing or Carius testing before standard microbiology resulted. And so they had found an uncommon presentation of chlamydia, as well as recurrent and metastatic complications of Staph aureus bacteremia. And so the exact role and timing of Carius testing remains unclear, but one potential use is to get earlier testing results given the rapid turnaround time compared to our traditional culture methods that take several days longer. Otherwise, it's often used as more of a salvage sort of diagnostic test due to the cost, which again is $2,000 per test, and as well as the lack of data for its exact role. So beyond sort of the concordance and those studies, a lot of those patients had already, at the time of enrollment, had a traditional diagnosis already. So really, what is the clinical impact of Carius testing, and is it impactful and worthwhile to do for our patients? So this was a retrospective cohort study at 5 US centers over 1.5 years. They had 82 Carius tests with a fairly even split between adult and pediatric population, with over half being immunocompromised. So they had a Carius positivity rate of 61%. And again, many did have more than one organism detected, which again is the challenge for the treating clinician to determine what is actually significant there. But Carius results led to a clinical impact in actually only about 11%, they estimated. So positive impact in 7.3%, negative impact in 3%, no impact in the majority. And here's how they define that. So a positive impact, meaning there was a new diagnosis or earlier diagnosis, they were able to avoid invasive therapy or start appropriate therapy. A negative impact, meaning that it led to unnecessary treatment or diagnostic procedures or a longer length of stay. 10 patients had additional repeat testing. They found that overall repeat testing after the first had little clinical impact if it did not on the first round. The concordance rates were about 60% again. The three new diagnoses made by Carius included, however, an abdominal aortic mycotic aneurysm caused by emphicalis and prevotella, diagnosis of rhizopus, which confirmed disseminated mucormycosis, and identification of mixed oral flora in a case of culture negative endocarditis, which did facilitate de-escalation of therapy. The three cases associated with the negative clinical impact had resulted in additional unnecessary diagnostic interventions in 2 and unnecessary treatment in 1. Among the positive Carius results, the lack of clinical impact is most commonly due to identification of a new organism that they did not act upon. And so that's again where you're coming up with probably those multiple organisms, some of that noise, and determining what's relevant there. The other half of those without significant clinical impact was because it just confirmed conventional microbiological results. And so it did not actually impact treatment beyond that. So patient selection practices here may have impacted this low clinical impact though, since many patients had already had that traditional microbiological diagnosis before sending the Carius test. And so this really highlights that we really just don't know yet the right role for the test in relation to standard workup. Interestingly, at the onset of this study though, no center required ID approval for Carius testing, but by the end, 2 of the centers had enacted some stewardship role requiring either ID or microbiology approval. And the clinical impact here was also based solely on the treating team's interpretation of the Carius test results. And so that would have an impact on their outcomes as well. So this was a similar study in a pediatric population. And so they actually found very high concordant rates of 94%. There was a higher yield for Carius testing in immunocompromised patients. They were more likely to have a positive result with a clinically relevant pathogen than non-immunocompromised hosts. Over half were considered clinically actionable, so much higher in this study. They had also highlighted potential for avoidance of 34 invasive procedures, which I think is really where one of the potential benefits stands. If we can better define the right time to send this test and the right host to send this test in to avoid some of those invasive procedures, biopsies, bronchoscopies, etc. They also had a higher yield from Carius than their invasively obtained samples here. They did still note, as we've talked about before, false positives and multiple organisms found in patients. And here they identified that specifically in patients who had disrupted GI mucosa. So probably picking out a lot of their biome. So knowing what you know now, would you want to send a Carius test on our patient, or would you continue standard diagnostics and care? So I'm going to see if I can open up poll. Actually, maybe Thomas, do you know, maybe I can't do it. Well, sorry, folks. Last time I did a Zoom presentation, I was able to open a voting poll. I'm not seeing that option here. So you can think about what you would want to do for this test, this patient. And we'll get back to our patient. So given the topic of today's talk, you probably aren't surprised that we did decide to send it. And so here was our patient's report. So his information is redacted at the top here, but you can see the crux of it here at the bottom, which is the organism detected, which was Mycobacterium tuberculosis complex at actually a pretty high MPM, molecules per microliter quantity. Here is the quantitative plot. And so the star again is our patient. They had detected it in 4 of the last 1,000 samples. And so those are the quantities that they had detected in other samples. And And again, from your asymptomatic reference cohort, 0%, which of course we should not be finding active TB in normal healthy volunteers. So again, I'm sorry, I thought I was going to be able to open polls, but think about what you would do at this stage. Would you repeat the Carius test? Would you wait for concordant AFB cultures? Would you go ahead and start empiric anti-TB therapy? Do all of the above? Ignore this result entirely because it was out of left field and continue routine neutropenic fever management. All right, well, I'll share with you what we did. So our next steps, I did speak with the Carius medical director since it was such an unexpected result and one for them as well. We collected blood and urine AFB cultures, requested sputum AFB, although the patient was actually not coughing or having any sputum production or respiratory symptoms at that time. We ordered quantiferon gold or IGRA. We obtained a chest CT, which you can see here, which essentially did not have any findings concerning for active tuberculosis, though they did find evidence of prior granulomatous disease. Looking farther back, this had been noted in a chest x-ray much earlier as well, although being a farmer in Virginia had been thought to be likely old histo at the time. We did start the patient on empiric RIPE therapy within days of our positive test result. So we started his empiric RIPE. At that time, he had normal baseline LFTs, no respiratory symptoms, and again, clear chest imaging from that last image that you saw. Within 1 day, the billy started to rise. A few days later, he developed a diffuse maculopapular rash, which was biopsied and found to be consistent with a drug rash. So we changed him from beta-lactam therapy to aztreonam, cipro, and metronidazole. The patient did defervesce a few days later after starting TB therapy, and then recovered his neutrophil count the following day as well. At that point, interestingly, he had developed some hypoxia, which actually escalated to the need for high flow nasal cannula. The CT you can see here, he had some scattered central lobular nodules in the right upper lobe, and then some ground glass reticular changes in the left upper lobe, which had been new from the week before. But they were sort of vague and not well defined. He did have mutant lymphadenopathy on the CT chest as well. He weaned off of oxygen about 10 days later. He also underwent bone marrow biopsy for his AML, which was stained for AFB, and then induced sputum finally, since he was not able to produce any himself. We did also send a repeat Carius test, which Carius actually offered to do this follow-up test free of charge for us since they were so interested in the case and the first result was so unexpected. So we obtained the repeat after 1 week on RIPE therapy. And here you can see they didn't give us the plot because at this point the MTB DNA levels were still detectable, but they had dropped to 102 mpm, which would typically be below the threshold for reportable. And I had addressed this in some of the earlier studies as well when they're below this threshold. Just from my experience of the few times this has happened, even though it is technically below their reportable threshold, if it is an unusual organism, I've always had one of the physicians from Carius still call me to have this discussion and let us know that it was still present there at a low level, in case clinically we found that to be relevant. Incidentally, on this report, they had also found HHV6. This, again, is probably kind of falls under that category of noise since he was likely shedding in the setting of being profoundly immune compromised. And so we didn't target the HHV6 with any additional testing or treatment. So our patient moving forward continued to have sort of gradual rise and plateau of his bilirubin levels. Eventually, we stopped the rifampin once his billy had reached actually 12 and substituted a fluoroquinolone. Then the following week, actually ended up holding all of his TB meds when his billy had continued to rise up to 16, and then he started to have a new transaminitis. Liver biopsy days later confirmed drug-induced liver injury. Interestingly, there were no granulomas present on the liver biopsy since he could have also had TB hepatitis as part of this disseminated TB infection. He may also not have formed granulomas due to his immune-compromised status. AFB stains of the liver pathology was also negative and culture negative. We did request 16S testing, although ultimately this was either not sent or not resulted. So although that's beyond the scope of what we're talking about a little bit here today, 16S testing is another form of molecular testing, which still has a little bit of an unclear role yet. So it's universal broad range PCR amplicon sequencing. And so that's performed on gene regions which are conserved across classes of pathogens. And so you can send this for bacterial, fungal, or mycobacterial specimens. And this is sent generally from tissue samples, either fresh or preserved tissue samples. A recent retrospective review by Kirchhoff, which was in CID, demonstrated low overall positivity rates of only 16.5%, and even lower impact on clinical management at 4%. Universal PCR was more likely to be negative in the absence of pathology findings, which was the case here for our patient. So it's not clear that even had that been sent, that 16S would have added probably to his diagnosis. And so, just interestingly, that's another example of really how unclear roles are for new molecular diagnostics at this time. So I also reached out to the Global TB Institute, which is our regional center through the CDC for TB consultation. I spoke with two physicians from the Global TB Institute who were both very excited about this case and agreed that it was unprecedented in terms of how it had been diagnosed. One recommended that I speak with the CDC TB lab to inquire about whole genome sequencing. So I did speak with the CDC TB lab director, but unfortunately they were not able to do testing on a blood sample. They needed an actual isolate, which we did not have since it didn't grow in culture. And speaking of his negative cultures, we also had discussed the impact of prior antibiotic therapy. So he had been on a short interval of levofloxacin prophylaxis, which does have mycobacterial activity before receiving cefepime for the first neutropenic fever. He had also then been on a substantial duration of meropenem prior to obtaining all of our AFB cultures and prior to starting RIPE therapy. So going back to look at the primary literature, actually 14 days of meropenem, usually in conjunction with a beta-lactamase inhibitor, does sterilize TB cultures. So possibly our patient's AFB cultures were all negative due to the meropenem treatment that he had received as part of his neutropenic fever course. So they advised to continue to monitor for development of pulmonary TB in the setting of immune reconstitution, which was the concern that he was potentially developing when he had worsening hypoxia and some changes in his CT. Ultimately, these all resolved on their own, or well, he was on therapy. And then lastly, he was a cattle farmer and drank unpasteurized milk from his friend's dairy farm. So I also wondered about the possibility of M. bovis, which would have different treatment implications, but may otherwise just be picked up as part of the MTB complex. Though there is still M. bovis in parts of the United States, though, the physicians at the Global TB Institute reassured me that there has not been any M. bovis in Virginia for at least 30 years. And then per discussion with the Carius medical director, they're not actually able to distinguish bovis from MTB complex at their current level of sequencing. And so from there, then I had a decision of whether to reintroduce TB therapy after his drug-induced liver injury, either gradually as per this New York City protocol, which you can see outlined here, or to use a liver-sparing regimen, which would be something like ethambutol, levofloxacin, linezolid, and amikacin. With a liver-sparing regimen, the impact of duration of therapy is really unknown once you're removing our most potent agents, particularly rifampin. I also continued clinical monitoring with the patient while he was off of therapy. He did not have any recurrence of fevers. We collected sputum AFB off of therapy, and actually he ended up only having one because we had to do it through his local health department. But that finalized negative, and his chest imaging remained clear at that point. Another thing that I started to pursue was through one of the NIH Mycobacteriology Labs, and that was investigational use of Mycobacterium TB specific peptide fragments in blood testing. And so they're also able to give a quantitative measurement via mass spec. They found very good sensitivity in their published data thus far, with over 91% sensitivity in culture positive pulmonary TB. So for our patient who would have culture negative extrapulmonary TB, sensitivity is lower at about 75%. But I'm actually still trying to follow up with this lab. We have a saved frozen serum specimen to try to do some of this testing as well, just for additional confirmation. Although between the patient's clinical scenario and 2 positive Carius tests, I, as well as his primary team and the consulting TB physicians, all interpreted this as a true and positive result. One of the benefits, however, of this MTB specific peptide fragment testing is that you can also follow trends for treatment response. So getting back to our patient, I was hoping to gradually reintroduce his right medications via that New York City protocol. But since his LFTs had still not normalized by the time he needed to start consolidation chemo, resuming anti-TB drugs became more urgent. And so at that point, then I decided to start him on a liver sparing regimen. And so we started levofloxacin, linezolid, ethambutol, and amikacin. He did okay during that initial admission for consolidation chemo, but was readmitted shortly thereafter with a fall in dizziness. So there was concern that amikacin was contributing to some of vestibular toxicity, and so we stopped the amikacin. He had also had delayed count recoveries beyond what was expected, which probably may have had some contribution from his regimen, particularly linezolid. And then ultimately, he ended up developing really severe nausea, loss of appetite, and weight loss. So for me, it was hard to tease apart how much of that was following chemotherapy versus his TB regimen. Though for those of you who have treated patients for TB or even latent TB with a single agent, you know that the GI side effects can be pretty profound from some of these drugs. And so he and his wife felt so strongly that it was due to the TB meds and wanted to stop them. And so we did hold them for a few days. And he did actually have then at that point complete resolution of his symptoms to the point that he was able to eat and felt much better. So from there, then between his intolerance, then I had opted to not resume the amikacin or the linezolid, which I think was probably the main culprit of his severe nausea. So at this point, then reverted back to the New York City protocol for resumption of his more standard TB drugs. At this point, his LFTs have been normalized, and so I started him back on INH and B6. Because of the issues with nausea, did have him take it at night before bedtime, which is how many patients find it to be more tolerable. Added back then subsequently pyrazinamide, then ethambutol. Where we are right now is our next step is to either complete the regimen with those 3 for, again, an unknown duration of time, but potentially up to 18 months, versus adding back a 4th drug. And so that may be rifabutin rather than rifampin because of drug-drug interactions with this chemotherapy, if those will be manageable, versus adding back a fluoroquinolone. But again, at this point, he is clinically doing well. He has not had any recurrence of fever. He's eating again and continues to feel well. So that's where our patient is as of right now, still going through his TB treatment and fortunately tolerating his consolidation chemotherapy well, since he is on active TB drugs. So in summary, Carius cell-free DNA sequencing may offer new diagnostic options, particularly in certain immunocompromised hosts or certain scenarios like endovascular infections, culture-negative endocarditis, and fungal pneumonia. There are numerous benefits to Carius testing, including its broad-ranging scope of over 1,000 pathogens, quick turnaround time of about 24 hours. Concordance may vary, but again, I think in some studies with the right host and the right timing seems to be good rates of concordance. And additionally, that it is at least some salvage diagnostic method for really refractory cases where you suspect occult infection. There are several drawbacks to Carius testing. A cost of $2,000 per test is significant. It still has an unclear place yet in workup algorithms in terms of use as a salvage regimen, salvage diagnostic tool versus testing early, because we have seen the impact of therapy on positive test results. Also not well defined yet, again, for which hosts and which infections, but this is the best methodology. And additionally, high chance of getting false positive results, including either multiple pathogens or colonizing pathogens, or false negatives while the patient's on therapy. So to address some of these, there is a multi-center study going on currently between centers. Here at VCU, we're also starting with our HEMONC colleagues, a retrospective review of our Carius testing in-house in terms of concordance with traditional methodologies and probably clinical impact as well. And then we hope that following our retrospective review, that we'll be able to move forward with a pilot study, ultimately with the goal of better defining its role in the neutropenic and cancer population. So with that, I'll wrap. Thank you so much, everyone. And I don't know if there's any questions in the chat or that I could address. Great. Okay, I don't see any questions. So thank you, everyone.
Great job, Megan.
Thank you.
Enjoyed that.